Hi, this is Callum, and this is Kidney. So the first thing to say is this is not quite normal. Unfortunately, this is the section that I had available to me for this, but I am about as far away from an expert in renal pathology as you could imagine. And so for our purposes here, for this video, I think this will be sufficient. We're just going to go through this at a very basic level, reviewing some principles of renal histology aimed at people who haven't perhaps seen renal histology for a long time, or perhaps not in detail at all. So at low power here, we can see the architecture quite nicely, because this is actually an excision specimen from a nephrectomy. It wasn't taken for anything that we can see here. It was actually taken for, this patient had TCC, or urothelial carcinoma of the ureter, and as part of the surgical excision, the kidney was taken out. So out here, this is the sort of lumen of the collecting system of the renal pelvic calyceal system up here, and on this side is which is the perirenal fat out here. So this is just fat out in this side, the perinephric fat, as it's called. Incidentally, that's the fat I think we get suet from in animals. That's an aside. This is the renal parenchyma, and this is all lined by a layer of dense connective tissue. This is this pink stuff around the outside called the renal capsule. So under normal conditions, that is intact and separates the perinephric fat from the parenchyma. So the parenchyma here of the kidney has made up of two layers. So there's the renal cortex, which is this from about here all the way down to about here. That's got the glomeruli in it, as well as lots of tubules. And then there's the renal medulla, which is this bit, which has just got tubules in it, and it's a bit paler at low power. There's also the renal pelvis here, which has got fat in it, renal pelvis fat, and also big blood vessels and some connective tissue. And beneath that, we've got urothelium, which this is a renal calyx, and it is lined by urothelium. If you zoom in a bit, this is stratified transitional epithelium, or urothelium, which has got the it's stratified. It's got a few layers on top of one another, lined by the kind of broader cells with fluffy, more indistinct pink cytoplasm, which is the umbrella cells, and that's the same as the urothelium we saw in the bladder, and it's this urothelium is continuous along the whole urinary tract. Okie dokie. So a quick review. We've got glomeruli here. Emerging from the glomeruli of the renal cortex are the proximal convoluted tubules, which follow a convoluted path, as the name suggests, and then turn into the descending loops of Henle, which descend right down, sometimes into the renal medulla, and then turn back round and ascend as the ascending loops of Henle. Follow a convoluted path in the distal convoluted tubules up here in the cortex again, before emptying into the collecting ducts. The collecting ducts drain the urine now through the renal cortex into the renal medulla and empty into the calyxes. The calyces are continuous with the renal pelvis, which is continuous with the ureters, which feed into the bladder, and so on into the urethra. And the whole tract there is lined by transitional or epithelium or urothelium. Okie dokie. If we look here, we've got a kind of more close-up of the renal cortex, in which we can see these structures, the renal corpuscles, or the glomeruli, and then surrounded by lots of tubules. So this will be a mixture of proximal and distal collecting tubules. There'll be some collecting ducts here as well, and loops of Henle. all interspersed with one another. So the renal corpuscles, we're probably not going to get a really good section of this, but they are fed by afferent arterioles. Sometimes you can see the afferent arterioles leading into the glomeruli. I'm not seeing I'm not seeing that so far. Sometimes you can see a good section where you can see an afferent arteriole leading into the glomeruli, and I've not seen that. If we come across that, I'll point it out. That's maybe an afferent arteriole leading in. Not sure. Anyway, sometimes you can see that, and it would have been good to demonstrate that, but it kind of shows you the practical aspects of looking at three-dimensional structures in a two-dimensional section. There's an afferent arteriole, or an efferent arteriole indeed, not exactly sure, leading into this glomerulus. So we've got erythrocytes in there, the lumen, so I know that's definitely an arteriole. Okay, that's good, we've seen that. Oh, and here is another one. We will have the afferent and efferent arterioles at this pole, and in the opposite pole you can see the beginnings of the proximal convoluted tubule emerging here. Good, so this is a good section to show you. So this is a renal corpuscle. It is made of a capsule called Bowman's capsule, which is lined by a simple epithelium, which is the parietal epithelium. Within that, there is this blank space called the Bowman's space. That's the white space, within which the glomerulus hangs. So these are the loops of the glomerulus, all this stuff here. So that's really the glomerulus within the renal corpuscle. So if we look in a bit further, we've got a kind of quite difficult to discern collection of cells here, but hopefully you can identify some loops, and these are capillary loops here. And essentially there are three main layers. So there are two lumina. So there's the kind of space of the Bowman's space, and then there's the space within the vascular lumen, the capillary loops. And there are three layers that separate these. So if we start from the vascular side, capillary loops are lined by endothelium. So that's the first layer, the endothelium of the capillary loops. The other layer, the opposite layer that lines the Bowman's capsule, are the podocytes. So that they're epithelial, the podocytes, and they are also known as the visceral epithelial layer, which is continuous actually with the parietal epithelial layer of the Bowman's capsule. So on this side, we've got epithelium, the podocytes. On the vascular side, we've got the endothelium. And in between that, we've got the mesangium, which is just the sort of ground substance between the two layers, and a thin basement membrane called the glomerular basement membrane. Now there is a cell within this mesangium called the mesangial cell. So some of these will be mesangial cells, which just help maintain the mesangium. But that's the three layers. So endothelium, mesangium, and glomerular basement membrane, and which are together in the same layer, and then the podocytes, or the visceral epithelium. So that's pretty much it. Out here in between the glomeruli is called the interstitium, in which there are lots of tubules, as I mentioned. It's not normal to see this degree of inflammation here. There shouldn't be much inflammation at all within the kidney under normal circumstances. This is chronic inflammation. These are all lymphocytes. Maybe there's some histiocytes among all this, and that's not normal to see that. The other thing that's probably not normal to see is this degree of scarring. So you can see scarring of the glomeruli, which we call glomerular sclerosis. See here, a big pink scar where a glomerulus once was. These are globally sclerosed glomeruli, i.e. the whole glomerulus is sclerosed or scarred. And that's not normal. Probably a certain degree of globally sclerosed glomeruli are present within as you get older, but this is maybe a bit more than you should normally see. But I'm no expert on this. So that's about it. I think if we scoot down to the renal medulla, it's quite unexciting. Just lots of tubules and connective tissue. Not really much to say. And yeah, so that's the kidney. So there are three main circumstances where you will see kidney. One is in autopsy practice, which I'll not talk about. The main time you're going to see kidney is in surgical practice, which is taken out when a kidney is taken out because it's developed a tumor. The most common tumor and reason for nephrectomy is a renal clear cell carcinoma, which is an epithelial tumor which is arised from the epithelium of the parenchyma here. And your main purpose then, once you've diagnosed the type of tumor, is to stage it. So has it invaded the perinephric fat? Has it invaded the renal sinus fat? Is it within the blood vessels? Is there vascular invasion? The other main circumstance where you'll see renal pathology is renal biopsies, and these are taken they can sometimes be taken to diagnose tumors, but they're often taken as part of medical renal pathology. Now that is a very different beast, where you look in great depth at the glomeruli, the tubulointerstitium, the blood vessels. You characterize the inflammation, the different changes that are happening within the kidney on H&E, and also with using special stains. It is the only routine use of electron microscopy within pathology is in medical renal biopsies. So you routinely use electron microscopy to look at these as well, to look in great detail within the glomeruli, where you can identify the structures that I was talking about earlier, the podocytes and the endothelial cells and the mesangium, etc., and the basement membrane. You also use immunofluorescence as well, routinely, and you put all this together, and this is a really complex area, and you put all this together with a lot of, it requires a lot of clinical pathological correlation, and really only specialist renal pathologists do that. And you'll get exposure to them throughout your training, but that's more advanced. So those are the three main areas where you'll be seeing kidney. Okay, that was a whistle-stop tour through kidney histology. Hopefully that was useful. Not my specialist area. So let's move on. I'll speak to you soon.